So I have this unenviable task of trying to distill down follicular lymphoma, probably about 20 minutes or half an hour. And what I thought I'd do is, it's going to be quite informal, but what I wanted to do was kind of give a kind of an intro, a bluffer's guide on the disease, on where we are currently from a treatment perspective, from a biology research perspective, and maybe how to navigate some of the bottlenecks to sort of improve, hopefully, outcomes for patients. So I'll just start with, let me share my slides. So, like I said, quite informal. Some slides may seem quite simple, but I just thought I'll just start from a baseline and we'll sort of work our way up. So lymphomas are, so first of all, just reminding everyone that lymph nodes are part of the body's immune system. So the cartoon, the schematic on the right just shows you locations of where you would expect to find lymph nodes in a patient. They're part of the body's immune system. Within the lymph nodes, you have what are called lymphocytes. And these are types of white blood cells whose role is primarily to fight infection, and also to try and eliminate sort of foreign bodies within the body. So lymphoma is a cancer of these lymphocytes within these lymph nodes. And there are two main types of lymphoma. So there's what's called Hodgkin's lymphoma and non-Hodgkin's lymphoma. We sometimes refer to this as NHL. And follicular lymphoma is a type of non-Hodgkin's lymphoma. So that's what obviously we're going to focus on today. So just to give you some statistics, lymphomas, for people that are diagnosed with lymphoma, they've probably never heard of lymphoma until they've actually been diagnosed. So this is just data from Cancer Research UK, and showing you that basically in the Western world, non-Hodgkin lymphoma is probably the 5th or 6th most common cancer type. So you have your usual suspects like breast and lung cancer, they're in the top 2, but non-Hodgkin's lymphoma overall is the 5th or 6th most common. So Hodgkin is just what it looks like under the microscope. So, and the incidence or the age range is very different. So Hodgkin's tends to present in younger individuals, from the age of 16 to 25. So they're much younger. It's probably one of the most curative cancers. So it's sort of the treatment is very different, essentially, because the biology is very different, essentially. So when we talk about non-Hodgkin's lymphoma, I actually think of it as a constellation of many diseases. There are probably over 60, 70 different non-Hodgkin's lymphoma. Follicular lymphoma probably accounts for about 25% of cases of non-Hodgkin's lymphoma. So really, it's a very diverse bunch of diseases. So even though we put it under this umbrella term of non-Hodgkin's lymphoma. So these are kind of the key facts about follicular, and this is what the kind of things I go through in my patients when they present. So follicular is what's referred to as an indolent lymphoma, so slow growing. Many of the patients will probably have had the lymphoma for several years before they have any symptoms. It's the most common type of indolent lymphoma. And in the UK, we probably diagnose about 2,500 new cases each year. But because of the kind of natural history of the disease, many of these patients will have treatment, are alive with treatment, and it is actually the most prevalent lymphoma because many of these patients live for many years with the disease. But we still refer to the disease as this lymphoma type as incurable, although I think that will probably change in time. I think there are patients who have received transplants and CAR T therapy that are probably cured with those treatment modalities. But for the majority of patients, we still refer to their lymphoma as incurable. The typical symptoms that the patients will present with, most of them will have a swelling of their lymph nodes, or they'll notice a lump, usually in their neck or their groin, that becomes enlarged. It's usually painless, they just notice it. And that may be the only thing that they notice, just a lump in the groin or the neck. The other symptoms that they can have is what we sometimes refer to as B symptoms. And these are, they may have lost a bit of weight unintentionally. They may have a fever that is unexplained. And they may have sort of tiredness or night sweats. So these are what are called B symptoms. But for some majority of the patients, they could be completely asymptomatic apart from the swelling of the nodes. So in terms of the average age of diagnosis, it's about 65 years. It's slightly more common in women than in men. And for reasons that is still not clear to us, it's not very common in Asian and African ethnicities. I always say to people, it's not an inherited disease, and the cause of follicular is still not very well understood. It's a very difficult question. I think we talk about something called functional cure. And the reason why I think as clinicians, we always are a bit nervous about saying that someone is cured is because we do see occasionally patients that have had a transplant, 10 years out where their disease does reoccur. So we are quite nervous about saying that the patients are cured. I think that we are beginning to see the data. So the more data we collect over time, we will be able to identify the patients that are cured. So I tend to always say the patient is in remission because the difficulty is if you say someone is cured and then their disease comes back, I think it's a very hard discussion to have. So I talk about remission more than I talk about cure. So there are two types of transplants. There's one that's called an autologous transplant. So what that means is that from the individual who has the lymphoma, you collect stem cells from them after they have had treatment. So in other words, you would have treated them with chemotherapy to try and reduce the burden of their disease. And then you collect stem cells from them, and that gets reinfused into the same patient. So that's what's called an autologous transplant. And then the second type of transplant is called an allogeneic transplant. So allo meaning coming from someone else. And usually you collect stem cells from another individual, and that gets transplanted into the lymphoma patient. It's a really good question. And I think that's the answers we don't know. I mean, this is why we typically follow all our follicular lymphoma patients. So we never discharge them, even after they've had treatment. And I've got patients in my clinic that are 20 years out from a transplant or chemotherapy that are probably cured, but that proportion obviously it's not a high number, and that's what makes it difficult for us to say that the majority of patients are cured. I think personally as a physician, there are patients that are cured because of the length of time that a disease hasn't come back, but we have no way of quantitatively telling them that. I can tell that because of the length of time they've been in remission for, but I have no way of measuring that and saying, oh look, but doing a blood test, you're cured. We just don't have those tools at the moment. So in terms of the diagnostic test, we typically do a biopsy from the swollen lymph node, and the diagnosis is confirmed by our pathologist by looking at the tissue under the microscope. It's important to say that there is no detailed routine genetic profiling. I think across the world, I think certainly in the States, in certain academic medical centers, there is routine genetic profiling, but it's not acted upon. I think that information is just banked for a rainy day. So we certainly don't do it because it doesn't influence the treatment that the patient subsequently has. Unfortunately, there isn't. There is some work in this area, not a lot, to see if there is a screening test. There isn't at the moment. There is some suggestion that there are some individuals that you could predict that they will go on to develop follicular lymphoma, 4 or 5 years before they're actually diagnosed. But that test doesn't have enough sensitivity. And the reason why people are a bit reluctant to pursue tests like this, particularly for an indolent disorder like follicular lymphoma, is if you do tell someone that they're going to develop follicular lymphoma, we don't actually have we can't intervene yet because we don't know whether intervention will actually have any impact. So this is just, I mean, when I started training in medical school, the outcomes for follicular lymphoma was probably in the region of about 8 to 10 years. So you'll probably see this sort of phrase, median overall survival, and what that means is, about, what do 50% of the patients with follicular lymphoma do? What is their survival overall? And this is what's called sort of survival curves. And what's been shown is that with each passing era, the outcomes have improved. So patients that were diagnosed in the early 2000s have probably had outcomes of about 10 years. Those that are diagnosed much later now have outcomes of about 20 years. And so I think obviously there's been significant improvement in probably the last 1 to 2 decades. Just to put things in context in terms of the prognosis, so I always say the discussion I always have is I explain that it's an indolent lymphoma. I explain that on average, or the median is probably about 20 years. We always look at a parameter, something called a 5-year overall survival. So this is just telling us that if you look down the road in 5 years after diagnosis, 90% of the patients with follicular lymphoma will still be alive. I think, and this is, most will see this as very impressive statistics. I'll just give you some comparators. So breast cancer, they're probably about 25 to 26-fold higher number of cases than follicular. The 5-year overall survival is very similar to follicular lymphoma. And then I'm going to just contrast that with a very poor, a cancer that is obviously has very poor outcomes. So pancreatic cancer, probably about 4 times the number of cases than follicular. The 5-year overall survival is less than 10%. So obviously, just to give you some, just to be able to compare different disease types. And then what I just thought I'd do, just to, just pique your interest a little, is I'm just going to show you the funding, Cancer Research UK funding, and sort of from last year, just across the disease area. So breast cancer, probably about 30 million was spent by CRUK. Pancreatic cancer, obviously a higher amount because of the poor outcomes. And then for non-Hodgkin's lymphoma, so these are the 60 different type of non-Hodgkin's lymphoma, it's 4.5 million. And I understand that probably less than 1 million went to follicular lymphoma from Cancer Research UK. So I thought that would just be interesting to see that information. So I'm just going to give you some examples of, these are 2 patients of mine that I see in clinic, just to give you an idea that every patient's clinical journey is slightly different. So this first patient here, diagnosed at the age of 36, so very young, a very young patient. And I've just charted their clinical history. This patient is still alive, 25, 30 years later. But you can see that her clinical history is punctuated by many episodes of the disease coming back. So each of these, when I've written FL1, FL2, FL3, this is her disease coming back. And each time she may have treatment, so C represents chemotherapy. Sometimes she's just observed because either she has no symptoms. But as you can see that in 25 years, she has 10 episodes of disease. So even though she is alive, we must remember that quality of life is obviously very important for someone living this long with many episodes of disease. On the other hand, this is a second patient of mine that I looked after, diagnosed at the age of 48, has what would be considered conventional standard therapy, but then within 2 to 3 years, the disease becomes more aggressive, and unfortunately he dies within 3.5 years of his diagnosis. So the patient's clinical journeys can be very, very different. And this is really highlighted by the fact that we now understand that there is probably about a group of patients that are referred to as high-risk follicular lymphoma because the disease behaves in a more aggressive fashion. It probably represents about 15 to 20% of patients. These patients, when they first receive treatment, so standard treatment, they will still progress. So their disease comes back within 2 years. This term, they've referred to this group of patients as what are called POD 24 patients. And again, these are these survival curves, which to just familiarize you again. So for the patients that do not progress within the first 2 years, they have the 5-year overall survival, like I showed you, 89, 90%. But if your disease comes back within the first 2 years, only 50% of those patients will be alive in 5 years. So, it's a very, this is a very high risk group of patients. And similarly, if the patients transform to a more aggressive lymphoma, so they go from this indolent, slow-growing lymphoma to a more aggressive lymphoma, in a very similar vein, these patients, 5-year overall survival of 43%. So less than 50% of them will be alive in 5 years. So there is a huge need to understand this population better, and we don't know yet how best to treat this group of patients. So just to summarize the treatment, where we are in 2020, I speak from a more UK perspective, but we can talk about what happens in other parts of the world. If you have no symptoms, typically you would follow what we call watch and wait. And this is the approach that Nicola had when she was first diagnosed. So this is pretty standard in most parts of the world. Even though you've got the follicular lymphoma, if you have no symptoms, we would just watch it and see what happens. When the patient becomes symptomatic, we typically combine treatment. So we use something called immunotherapy together with chemotherapy, and this is the standard first-line therapy in many countries. There has been talk of what's called a chemotherapy-free option. However, the large clinical trials have shown that this option is not necessarily, it is certainly not superior to our standard approach. So it is not adopted in the UK, although it is an option in the US. So when I talk about, when I have a patient in front of me, I always talk about what the goals of treatment will be. And of course, it's typically what we're trying to do is you want to maximize the efficacy of treatment and at the same time balance that by minimizing both short and long-term toxicities, try to reduce the impact on their quality of life, reduce the impact of treatment on impacting their quality of life, and of course reducing the risk of the disease coming back or transforming to a more aggressive lymphoma. I always say to patients and to people that chemo-free doesn't mean side effect free. You just have a different profile of side effects, and that certainly was the case from this large study. The patients still have side effects, they just have a different type of side effects with a chemo-free option. So that's for first line. What happens when the disease comes back? And this is where it's a challenge, because there is actually no standard approach, and every part of the world does something slightly differently. But most physicians, what we try to do is, we select the treatment when the patient relapses based on what treatment they've had previously, how long they've been in remission for. Are they specific risk factors when their disease comes back? For example, obviously, if they're much older, how fit they are, have they got other comorbidities? And we factor that into our decision making, because obviously older patients tolerate more intensive treatment not as well. And the other thing we think about is whether the patient is fit enough for a transplant, because typically if a patient progresses, particularly quite early, we always think about transplanting the patient because we know that the outcomes for transplant are superior to some of the existing treatments available. So the next thing that's, I think, is usually a question that the patients usually ask me is, how long can if you treat me, how long will I be disease-free or in remission for after treatment? I think that with our current first-line treatment, our standard approach, most patients have what's called a progression-free period or a remission period of about 7 to 8 years. So this is about 50% of patients will be in remission for about 7 to 8 years with a standard first-line treatment. Now, what happens after their disease comes back? And this is where it becomes a bit challenging. So if their disease comes back a second, a third, or fourth time, the subsequent lines of therapy do not keep them in remission for very long. So most of them will have a disease-free period or remission, or be in remission for 1 year or less, apart from those that have a transplant where this period is much longer. So I think, of course, there is a huge need to significantly improve second, third, fourth line treatment should the patient require it. This is just highlighted by some data from New York, the Memorial Sloan Kettering Cancer Center, and they looked at a very large cohort of patients that they followed for over about 20 years. And this is just really emphasizing, where's my arrow gone, that, for the first line, most patients will probably have a remission of about 7 to 8 years, but then you can then see that it drops off considerably. So second line, 1.5 years remission, third line 1 year, fourth line less than a year, and so on. So this is where there is a real problem of how to improve this to a much higher number. So, like I said, with relapsed follicular lymphoma, there's no real standard approach. For some, it's again coming back to the immunotherapy, chemotherapy. For some patients that are fit, we would be able to offer them a transplant. It's important to say that some of these treatment for relapsed follicular lymphoma are only available in specific academic medical centers. For example, transplants will only be available in large academic medical centers that have experience with transplants. The other option for patients is obviously newer treatments, newer targeted therapies, clinical trials looking at things like CAR T cells, bispecific antibodies. I'll talk a little bit about this today. Again, the thing to think about with these new therapies and clinical trials is, is the drug approved in the different countries? So some countries have the drugs approved there, others don't. So obviously only patients from certain countries will access those treatments. Are the trials available in that country? And most of these sort of treatments, again, are typically within academic medical centers. So patients may have to travel a distance to be able to get access to some of these newer treatments and clinical trials. I thought I would just put in some sort of treatments that have either been recently approved or on the horizon. I will talk a little bit more about this next week in the board meeting. There are sort of drugs that target the lymphoma cells themselves, some that targets the kind of signaling pathways that keep the lymphoma cells alive, others that try to modulate the immune system to try and make the immune system sort of more supercharged so that it could be directed against the cancer. And then obviously there's a whole new wave of immunotherapy, which is very exciting, cellular therapy, CAR Ts and bispecifics. But these are kind of the drugs that either have been approved or are on the horizon for follicular lymphoma. So this is kind of, I always say that the treatment that we have at the moment, and this is probably the same across most cancer types, is quite biology agnostic. You typically use a treatment, or sort of a one treatment fits all approach. And the hope is that by incorporating a better understanding of the biology and incorporating that, you may lead to more precision treatment approaches. I'll just give you an idea of where we are in terms of the biology of follicular lymphoma. I think that there has been a lot of progress in the last decade. We now have a very good understanding of what I sometimes call the genetic sort of catalogue of follicular lymphoma. And this has come about by, sequencing, taking the tumors of patients with follicular lymphoma. We've probably sequenced around the world, probably over 1,000 patients. And this has allowed us get a better idea of what the genetic sort of encyclopedia, what genes are most frequently mutated in these cancers. This is a kind of a gene cloud, just to give an idea of what these genes are. The key take-home message from this slide is that we now know that probably about 90% of follicular lymphoma patients have mutations in something called the epigenetic machinery. And the epigenetic machinery is very important in dictating how cells behave. So I think this is where there's been a lot of progress. We now understand that this particular machinery is of high relevance in this type of lymphoma. The other area that has been, that we've made a lot of progress is we now understand actually that the follicular lymphoma tumor cells don't act on its own. They have a kind of a support, they've got a kind of support network. The immune cells that you hoped would actually be directed against the tumor cells actually work together with the tumor cells. So you have this kind of what we call the tumor's microenvironment interplay. So the follicular lymphoma tumors are able to subvert the immune cells to actually work on its behalf. And so what actually happens is that the tumor cells can sit in this very supportive ecosystem and be protected against the immune system, and it's able to escape the kind of immune surveillance, and that's why these tumors can persist for many years even before the patient has any symptoms. So some of the ideas that we now have based on the research is we're beginning to understand why we might not be curing follicular lymphoma. One of these areas is a better appreciation that, each patient's tumor is very different. And in a way, we probably knew that clinically, even from looking at patients and how they behaved. Some patients can have the disease, not have many symptoms, can be disease-free for a long period of time. And on the other hand, you have patients whose disease is very aggressive despite throwing our strongest treatment modalities at them. And this is what's called this inter-patient heterogeneity. Patients with exactly the same follicular lymphoma type of tissue, but actually when you look at the genetics of their tissue, it's actually very different between patients. And then what's actually been very interesting is that when we look within the single individual, so the same patient with follicular lymphoma, and if you look at how their disease changes in time, because as their disease progresses, we actually find that their tumors change, and either that's changing because they've had treatment, so the treatment is evolving to kind of become resistant or to escape the treatment. So this is very interesting and is particularly relevant, I think, when we think of things like the registry. You know, if you take a patient's sample at diagnosis, how representative is the disease compared to when the patient then relapses several years later? So there is this kind of biological heterogeneity in time. But then we're also recognizing, even within a single time point, if you take biopsies from different sites in the same patient, the tumors are actually can be quite different between different sites of disease. So this sort of appreciation that the tumors can be very different in space and in time. The other thing that we obviously now recognize from our research is that when we treat the patients, we seem to be leaving behind this sort of reservoir population, this sort of residual population that we call the cancer sort of reservoir. We've termed it CPC. I wouldn't worry too much about the technicality of what that means, but it's essentially a cancer reservoir. So these are the tumors. So if we imagine these are the tumors that patients can feel, when we treat them with a chemotherapy, what typically happens is that the bulk tumor that you can feel disappears. And then we're leaving behind this population, this cancer reservoir that we can't actually isolate, and we don't know where exactly it resides. And this population is quite drug resistant, and it can sit there for years and then return leading to the kind of progression of the disease. So we believe that for the patients where the disease returns, that we are leaving behind a cancer reservoir that our treatment is not eradicating. So just to kind of wrap up the last few slides, I'll just sort of talk about where we think the kind of the challenges are. I think that because follicular lymphoma is sort of perceived as a cancer with a good outcome, 5-year overall survival of 90%, they kind of park that in the, this is a good cancer type. And that means that research funding is prioritized elsewhere. There are no tools currently to identify the high-risk patients. There's 15 to 20% of patients that have a more aggressive behavior. So not only can we not identify these patients, we also really don't know how to treat those patients yet. We don't have a standard approach to treating them, even if we did identify them. So there's a lot of work to do in that area. I think there's a difficulty in funding large clinical trials in follicular lymphoma. And the reason for that is really the length of time, because most of these patients, when they treat them, they have a long remission, and therefore you'd have to have a clinical trial open for 6, 7, 8 years, maybe even 10 years. And of course, the associated cost with keeping such trials open. So there's a real lack of large clinical trials in follicular lymphoma. The other thing also is that a lot of the trials historically are used to ask a specific question with regards to treatment, but they miss the opportunity to look at what we call correlative studies. So they don't study the tumors to understand, what the biology is, why is the treatment not working, and this has really been lacking until recently. And obviously, I think generally the biology is not very well understood. We are playing catch up. I mean, there are lots of new treatments that are coming out, but actually we still don't know enough about the biology. And the reasons for that is because it's difficult to bank the fresh samples for research. There are very poor model systems that have been developed because they're probably not, when we think about the number of breast cancer researchers and the number of follicular lymphoma researchers, it's very, very a huge discrepancy. And of course, funding remains an issue across the board. So some of the ways that we could break down some of these bottlenecks is to try and understand the differences between the perceived good risk patients versus the high risk patients. Like if you understood the high risk patients better, you could design treatments that could be targeted at those patients subgroup. There are actually now a lot of different treatments for follicular, But actually what we don't understand is which patients will be served best by different therapies. How do you, and the way to do that is to try and understand if we can identify what are called biomarkers, so things that you could measure that tells you this patient is going to best respond to drug A, but is going to be resistant to drug B. And I think that this area is something that needs to be improved to allow us to select therapies for patients. And I think ultimately, the more we understand about this reservoir population, you may in some way find drugs that could target it and hopefully eradicate the tumors.